Hello, our dear students. Today we have a quarantine for infection COVID-19 and our department looking very boring, very sad without you. We all miss you so much and we will be glad to see you as soon as possible. But for today, stay home and it is not a cause to stop your education. We continue our distant learning for me and my teachers of our department, always online. We always ready to work you with in a classroom in different types of distant learning technologies. And here I want to start my lecture cycle online. And today I want to read a lecture for 4th year students for discipline internal medicine with endocrinology about diseases of adrenal glands, and we will stop on adrenal insufficiency, adrenal hyperfunction, and hormonally active tumors. Today we will have 9 USMLE tests. I ask you some questions, and in comments under this video I'm waiting for your answers. In my next lecture for 4th year students, I will give you my variants of these answers, but I'm interested in your activity. More of it, everyone who will see this lecture, I ask you write in the comments under the video your name and group and your variants of correct options for these 9 questions. Okay, USMLE test 1. A 34-year-old woman comes to the emergency department complaining of severe headache and anxiety, diaphoresis and palpitations for the last 30 minutes. She has had several similar episodes over the past few weeks. She has no significant past medical history and has 10-pack-year smoking history. She takes no illicit drugs. Her blood pressure on arrival is 181 by 80 millimeters head-radium. Her pulse is 134 per minute. The attending physician gives her 10 milligrams of metoprolol. How is the patient's blood pressure most likely to respond? First option is hypotension due to beta-adrenergic receptor blockade, hypotension due to alpha-adrenergic receptor blockade, hypertension due to alpha-adrenergic receptor blockade, hypertension due to alpha-adrenergic receptor stimulation, and hypertension due to alpha and beta-adrenergic receptor blockade. Wait for your answers. Okay, plans of today's lecture. It is to give in a definition, epidemiology, risk factors, etiology, mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, and prophylaxis of adrenal gland disorders. Okay, definition. In general, diseases of adrenal glands are conditions that interfere with the normal functioning of adrenal glands and may cause hyperfunction, overactive adrenal glands, or hypofunction, underactive adrenal glands, and may be congenital and acquired. There are 2 parts of adrenal glands, the cortex, derived from mesenchymal cells, and the medulla, derived from neuroectodermal cells. First one produces mineralocorticoids, glucocorticoids, and androgens. Second one produces epinephrine or adrenaline and norepinephrine or noradrenaline. Epidemiology. Like an example, I took Japan because they have a very good statistics. In Japan, in year 1997, were estimated 1,450 for primary aldosteronism, 1,250 for Cushing syndrome, 290 for adrenal preclinical Cushing syndrome, 660 for Addison's disease, and 1,030 for Pheochromocytoma. You see that it is not a very often disease, but it quite often to meet you in your future practice. That's why learning of these disorders is very important for you. For the first time, reliable national estimation of prevalence of disorders of adrenal hormones was conducted in this study. This study was the first. And like an example, in the right part, you see a picture of abdominal ultrasonography revealed a 5 cm heterogeneous node in right adrenal gland. Risk factors in general for all disorders. There are no appear to be particular group is the most at risk of adrenal gland disorders. Each age is, each sex, each race can be affected by adrenal gland disorders, and it is no significant difference between them. While there are certain risk factors for adrenal gland disorders, most of them occur without apparent cause, and risk factors are absent too. A risk development adrenal disease may be increased by genetic predisposition, by a problem in another gland, such as pituitary gland, or when the disease or infection affects one or both of adrenal glands. And certain lifestyle behaviors and environmental factors such as smoking and exposure of cancerogens. Okay, what about etiology? Like we told in risk factor, it is congenital abnormalities like predisposition. It is different immunopathology. It is infections like tuberculosis, acquired immune deficiency syndrome. It is a problem in another gland, such as pituitary, which regulate the adrenal gland. Tumors, including pheochromocytomas, bilateral adrenal hemorrhage or infarction, bilateral adrenalectomy. Certain medicines. Mechanism of adrenal disorders. The major disorders of adrenal cortex are characterized by excessive deficient secretion of each type of adrenocortical hormone, accordingly to interference of etiologic and pathogenetic factors that include distress, injury, vascular reaction, thrombosis, necrosis, acute and chronic inflammation, dystrophy, hypertrophy, neoplastic processes, etc. The most common disorder of adrenal medulla is pheochromocytoma that originates from chromatin cells and excretes catecholamines, but pheochromocytoma may be referred to as secreting paragangliomas then found in extra-adrenal cells, neoplasms such as neuroblastomas and ganglioneuroblastomas, also be neuronal lineage. In International Classification of Disease, we can find adrenal disorders in Chapter 4. It is in parts E26 and E27. Clinical manifestation. Yes, the main syndrome that we can meet, it is adrenal insufficiency, adrenal hyperfunction, primary aldosteronism, glucocorticoid-remediable hyperaldosteronism, pheochromocytoma, adrenal hyperandrogenism, non-classic congenital adrenal hyperplasia, androgen-secreting adrenal tumors, adrenal incidentalomas, in the considerations of pharmacologic use of glucocorticosteroids. And we will discuss the most often of them. The more rare syndromes we will discuss in your classrooms with practical class teachers. Etiology of primary adrenal insufficiency. Let's discuss it. The most common cause of primary adrenal insufficiency is autoimmune destruction of adrenal glands, like Addison's disease. It is from 70 to 90% of all cases in different countries. Some other causes of primary adrenal insufficiency that much more rare include bilateral adrenal hemorrhage, It is using of some drugs like mitotan, ethotimate, ketoconazole. Infection disease like tuberculosis, HIV infection, disseminated histoplasmosis, paracoccidomycosis that affects glucocorticoid and mineralocorticoid secretion and may be fatal if untreated. Addison's disease may coexist with other autoimmune conditions such as type 1 diabetes mellitus, hypothyroidism, and hypoparathyroidism. Secondary and tertiary adrenal insufficiency occur commonly after the discontinuation of glucocorticosteroids. Less frequently, adrenocorticotropic hormone ACTH deficiency may be caused by pituitary macroadenomas, pituitary surgery or radiation, and paracellular disease. Megestrol acetate, an appetite stimulator used in some patients with advanced cancer or cachexia related to AIDS, may be associated with secondary adrenal insufficiency. Tertiary adrenal insufficiency results from inadequate secretion of corticotropin-releasing hormone. Secondary and tertiary adrenal insufficiency only affect cortisol secretion because ACTH has only minor role in the regulation of aldosterone secretion. Manifestations of adrenal insufficiency in primary case complain of fatigue, anorexia, weight loss, skin hyperpigmentation initially on extensor surfaces. Palmar creases, buccal mucosa result from increasing levels of ACTH and other pro-opioid related peptides, including melanocyte-stimulating hormone. Secondary adrenal insufficiency manifests more invidiously with lack of skin hyperpigmentation, salt craving, metabolic acidosis, and hyperkalemia. Because mineralocorticoid secretion is intact, fatigue, hyponatremia, and hypoglycemia are some of clinical manifestations in secondary adrenal insufficiency. Okay, and let's divide all symptomatic to symptoms, signs, and laboratory abnormalities. I hope you remember the difference between symptoms and signs. It is subjective and objective findings during your examination. What is subjective? What patient can told you about his or her disease? It is a weakness, fatigue, anorexia, nausea, vomiting, constipation, diarrhea, abdominal pain, salt craving, postural disease, muscle and joint pain. Signs. Objectively, you can find a weight loss, a hyperpigmentation of skin, a vitiligo, a systolic blood pressure less than 100.10 mm Hg. And laboratory findings, it is hyponatremia, hyperkalemia, hypercalcemia, azotemia, anemia, and eosinophilia. And schematically, one more time, we can see, first of all, it is skin changes, it is hyperpigmentation, yes, mostly on these surfaces. It usually looks like patient returned from the seaside with a very dark color of skin, but patient did not were in a seaside. In some cases, we see discoloration of skin, like you can see in this patient. It is local discoloration that we named vitiligo. Very often in patients with adrenal insufficiency, we see GI symptoms. It is nausea, diarrhea, vomiting, constipation, and abdominal pain. More of it, patient usually complains to general symptoms like low blood pressure, significant weakness, and weight loss. In more extreme cases, in emergent cases that we name adrenal crisis, we can see such symptoms like fever, syncope, convulsions, hypoglycemia, hyponatremia, severe vomiting, and diarrhea. And evaluation. In evaluation of patient with suspected adrenal insufficiency, it is a three-step process. First step, to confirm is it present insufficiency or not, establishing. Second, it is differentiation between primary and secondary adrenal insufficiencies. And third step, it is looking for cause of this adrenal insufficiency. To providing a first step, we check an early morning 8 a.m. plasma cortisol level. In case when it is lower than 3 moles per deciliter, confirms adrenal insufficiency, whereas the value higher than 15 makes the diagnosis highly unlikely. Cortisol levels in a range of 3 to 15 may be seen in patients with primary, secondary, or tertiary adrenal insufficiency. The patient should be evaluated by cortrosine stimulation test and any time during the disease. Here you see an algorithm for confirming presence of adrenal insufficiency. Next step, it is differentiation if it is primary or secondary case of adrenal insufficiency. To differentiate between each other, it has been done through the measurement of basal plasma ACTH level. An elevated ACTH level is consistent with primary adrenal insufficiency. In case when it is low or normal range ACTH level, but previous step it was low cortisol level, confirms the diagnosis of secondary or tertiary adrenal insufficiency. Okay, and last step, it is determining cause of adrenal insufficiency. When the biochemical workup is consistent with primary adrenal insufficiency, computed tomography scanning of adrenal glands may help with the differential diagnosis. Enlarged adrenal glands or calcification suggest an infection's hemorrhagic or metastatic cause. In rare circumstances, CT-guided percutaneous fine needle aspiration of enlarged adrenal glands may help establish the diagnosis. Patients with tuberculosis adrenal insufficiency usually have an evidence of active systemic disease. MRI of pituitary glands in case if glucocorticosteroid therapy as a cause of secondary adrenal insufficiency is ruled out. Okay, and let's discuss USMLE test 2. In 53-year-old nurse presents the emergency department after experiencing a syncopal episode at work. She reports a 6-month history of worsening fatigue, 20-pound weight loss, and dizziness when standing up from the sitting position. Her PMH is significant to hypothyroidism, for which she takes levothyroxine. Her blood pressure while supine is 105/60, which falls to 75/50 when standing. On exam, she appears fatigued, and you note hyperpigmentation of the gums as shown in figure. I don't have figure here. Labs are not notable for sodium is 128 millimoles per liter and potassium of 5.6 units per liter. Which of the following is most likely pathology underlying this presentation? First option, it is autoimmune adrenalitis. Next one, infection adrenalitis. Third, hemorrhagic infarction of the adrenal glands. Fourth, metastatic disease involving the adrenal glands. And fifth, medication-induced suppression of adrenal glands. Waiting for your answers in comments. Okay, treatment of adrenal insufficiency. Patients with Addison's disease, like most often form, require lifelong replacement with glucocorticosteroids and mineralocorticoids. The dose is adjusted based on clinical status, including the presence or absence of orthostatic hypotension, hypertension, and electrolyte imbalance. Patients with secondary or tertiary adrenal insufficiency does not need mineralocorticoid replacement. Most patients can be educated to self-administer hydrocortisone and reduce the risk of an emergency room visit. All patients should wear some form of identification indicated adrenal insufficiency status. And in next slide you see medical identification. It is necklace or bracelets that absolutely essential with information for their diagnosis and treatment regime for patients with adrenal insufficiency. Okay, and emergent case, we discussed that it is the most severe case that we named adrenal crisis. Adrenal crisis or acute adrenal insufficiency is a life-threatening emergency which usually manifests with nausea, vomiting, abdominal pain, abdominal tenderness, fever, acute abdomen, and shock. Patients may be previously undiagnosed or have chronic primary adrenal insufficiency with no or inadequate glucocorticosteroid replacement. Treatment of adrenal crisis should not be delayed. Diagnostic workup in patients with no history of adrenal insufficiency should include a plasma sample for cortisol and ACTH level determination, immediately followed by an intravenous bolus of hydrocortisone 100 mg and adequate fluid replacement, normal saline. Hydrocortisone should be continued 50 mg every 8 hours, awaiting laboratory results. Okay, and next interesting question for you. Test 3. A 46-year-old female with history of type 1 diabetes mellitus presents with complaints of chronic fatigue, muscle weakness, and headaches. These symptoms have been present for a past year. Her vital signs today there are follows: temperature 36.9, heart rate 82, blood pressure 88 by 52 millimeters Hg, respiratory rate 14, and saturation is 98 on room air. Physical exams does not demonstrate any specific abnormalities. After injury, the patient reports that their blood pressure has always run low. Initial workup reveals an 8 a.m. cortisol level of 3.6. Which of the following is the best next step in management of this patient? First option, low-dose dexamethasone suppression test. Option 2, high-dose dexamethasone suppression test. Urgent 5 mg hydrocortisone injection. Fourth, cosintropin stimulation test and pituitary MRI. Okay, adrenal insufficiency in the critically ill patient. The overall incidence of adrenal insufficiency in critically ill patients is less than 10%, but an incidence as high as 15 in patients with specific septic shock has been reported. Invasive care unit Patients with hemodynamic instability despite fluid resuscitation, especially in the presence of shock, should be tested for adrenal insufficiency. Hydrocortisone 50 milligrams IV every 6 to 8 hours is an adequate replacement dose for critically ill patients with suspected adrenal insufficiency. Treatment with this dose should be continued for 2 or 3 days. After hemodynamic improvement, the gradual taper of hydrocortisone, depending on patient's condition, should be instituted. Okay, and selected a list of related disorders to adrenal hyperfunction. We start in new disorder. Disorders related to adrenal hyperfunction are relatively rare, but they have a significant mortality and morbidity if untreated. When the adrenal glands produce too many hormones, the symptoms vary depending on the disorder. Disorders related to adrenal hyperfunction include the most often we name Cushing's syndrome, and more rare it can be primary hyperaldosteronism, Pheochromocytoma, paraganglioma, and hormonally active tumors. Okay, what is Cushing's syndrome? Maybe you hear this term a lot of times and meet in literature, and let's discuss and confirm all our knowledges in our lecture. Cushing's syndrome is composed of symptoms and signs associated with prolonged exposure to inappropriately high levels of plasma glucocorticosteroids. Exogenous glucocorticosteroid intake is the most common cause of Cushing's syndrome. The endogenous causes are divided into ACTH-dependent and ACTH-not-dependent Cushing's syndrome. And here by this scheme you see the most usual manifestations of Cushing's syndrome. It is upper body obesity with thin arms and legs. It is buffalo hump, you see it by the arrow. It is red round face, high blood sugar, high blood pressure, vitiligo, blurry vision, acne, female balding, water retention, menstrual irregularity, thin skin and bruising, purple stria, poor wound healing, hirsutism, severe depression, cognitive difficulties, emotional instability, sleep disorders, fatigue. Okay, and what about classification? We told that it can be ACTH dependent and ACTH not dependent Cushing's syndrome. For ACTH dependent, we can see in most cases it is Cushing's syndrome 67%, but more of Cushing, it can be ectopic ACTH secretion, it's nearly 12%, and ectopic CRH secretion less than 1%. And for ACTH independent syndrome, it is in 10% of cases, it is adrenal adenoma. In 8% of cases, adrenal carcinoma. In much more rare cases, it is micro and macronodular adrenal hyperplasia. Clinical features. Yes, most specific signs and symptoms of Cushing's syndrome. It is pleural, it is supraclavicular and dorsal fat pads, it is central obesity, it is proximal muscle weakness, it is cutaneous wasting, purple stria. More of it can be spontaneous ecchymosis, osteopenia, hypertension, early or delayed puberty in children, and growth retardation in children too. And less specific signs and symptoms of Cushing. It is papular acne, vellus hypertrichosis of face, decreased libido or impotence, It is oligomenorrhea or amenorrhea, menstrual disorders. It is infertility, cutaneous and systemic fungal infections, poor wound healing, neutrophilisis, headaches, neuropsychiatric disorders, and spinal epidural problems. And by the scheme you see signs of Cushing syndrome. Here you see that it is central nervous system irritability and emotional disbalance due to affecting of central nervous system too. Under it, when we go slower, it is red and round face. We can see in patient hypertension. It can be cardiac hypertrophy, but secondary due to severe hypertension. It is finding of hyperplasia or tumor of adrenal glands. It is obesity, like we told, it is mostly central obesity, fat deposition on abdomen and back of neck. It is purple stria, yes, very specific sign of Cushing syndrome. More of it can be osteoporosis, muscle wasting, and skin ulcers. In females, it is often problems amenorrhea and hirsutism. In males, erectile dysfunction. Establishing the diagnosis. Yes, we have patient with suspicion for Cushing syndrome. Yes, we should measure and provide 1 milligram dexamethasone suppression test and 24-hour urinary-free cortisol determination. On result of dexamethasone test, if it is normal, no further workup unless suspect clinic Cushing syndrome. And by the result of 24 hours urinary-free cortisol determination, if it is normal, the same result. If equivocal, we confirm additional tests like the low-dose dexamethasone suppression test and determination by international prognostic score. If it's 3-4 times upper normal, it is established Cushing syndrome. And for further diagnosing, we determine ACTH. If it is suppressed, it is adrenal Cushing syndrome. It is CT, computer tomography of adrenal gland. If it is low normal, we do test for provocative tests too, and if it is normal or elevated, we do pituitary MRI, continue investigation, and finding way of treatment. For differential diagnosis, once Cushing syndrome is biochemically confirmed, the plasma ACTH level should be measured preferably in the morning. Suppressed or low ACTH level less than 10 picograms is consistent with ACTH-independent Cushing syndrome and should be followed by adrenal CT scanning. ACTH values of 10 to 20 picograms may be seen in patients with both adrenal and pituitary causes for Cushing syndrome. These patients should undergo a CRH stimulation test. A flat response to ACTH to CRH during the test suggests an adrenal cause, but a more than 50 increase of ACTH level is consistent with Cushing syndrome. ACTH levels higher than 20 picograms per milliliter suggest ACTH-dependent Cushing syndrome. About 90% of patients with ACTH-dependent Cushing syndrome have pituitary cause, and the rest are ectopic in origin. You should remember that tumors can be ectopic. ACTH level tends to be higher in ectopic Cushing syndrome compared with Cushing's disease, but there is significant overlap. A more than 50% increase in ACTH level after CRH test and more than 80% reduction in the morning cortisol level after taking 8 mg dexamethasone and 11 during high-dose DST is consistent with pituitary source and in the presence of pituitary adenoma almost establishes the definitive diagnosis of Cushing syndrome. If the CRH stimulation test and DST result are not concordant and MRI does not show a pituitary adenoma, then inferior petrosal sinus sampling to distinguish ectopic from Cushing syndrome is indicated. Localizing tumors that provide ectopic ACTH is accomplished by chest and abdominal CT studies, followed by neck CT if no source is found. And octoptide scan can be some value of patient with ectopic Cushing syndrome and negative imaging studies. And next step for you for today, it is a 35-year-old Caucasian female presents to a hospital alarmed by her recent transient weight gain, facial hair growth, and thinning skin. During physical exam, the physician finds the patient is hypertensive. Serum analysis reveals hyperglycemia. The physician suspected a pituitary adenoma, which dexamethasone test result from help confirm the physician's suspicion. First option, it is low dose increased ACTH, high dose increased ACTH. Second, low dose increased ACTH, high dose decreased ACTH. Third one, low dose decrease ACTH, high dose no change ACTH. Fourth option, low dose no change ACTH and high dose no change too. And last option, low dose no change ACTH, high dose decreased ACTH. Okay, treatment of Cushing syndrome. It can be surgical, like transsphenoidal removal of the ACTH-secreting pituitary tumor is a treatment of choice. Yes, the best variant to find a hormone-producing tumor and remove it by neurosurgery. Cushing syndrome caused by an adrenal adenoma is usually cured by laparoscopic unilateral adrenal ectomy. Adrenal carcinoma is an aggressive tumor with a poor diagnosis. Surgical resection at an early stage along with lifelong mitotan therapy soon after surgery offers the only chance to cure of long-term remission. Surgical removal of an ectopic ACTH-producing tumor results in cure. Medical therapy with ketoconazole, metirapone, aminoglycoside, or metaton may be considered for patients with a limited expectancy for all alleviation of hypercortisolemic symptoms without surgery. And next step for today, step test. It is 50-year-old female is evaluated by her physician for recent weight gain. Physical examination is notable for transient obesity, wasting for her distal, musculoskeletal, and moon faces. In addition, she complains of abnormal stretch marks that surround her abdomen. The physician suspects pituitary adenoma. Which of the following high-dose dexamethasone suppression test findings or baseline ACTH findings would support his view? First option, it is cortisol suppression, normal baseline ACTH. Second, cortisol suppression with high baseline ACTH. Third, no cortisol suppression, high baseline ACTH. Fourth one, no cortisol suppression, low baseline ACTH. Fifth one, evaluation of cortisol above pre-test high levels, high basal ACTH. Okay, primary hyperaldosteronism, the next disorder for today. It is abnormal high level of aldosterone. What causes can lead to this syndrome? The most common cause is idiopathic hyperaldosteronism. It means that in most cases we don't know why we see this syndrome in patient and we can't find any significant cause. The second most common cause, it is visible adenoma that produce aldosterone. And rare cause, it is glucocorticoid suppressible form with suppression of ACTH. With hybrid glomerulosa cells responsible to ACTH that affects producing of aldosterone. And you remember that aldosterone, it is a chemical that takes part in one of the most important regulatory system in our organism. It is renin, angiotensin, aldosterone system that functioning in kidneys. Okay, forms of familiar hyperaldosteronism. It is two main forms of familiar primary hyperaldosteronism. It can be type 1 or glucocorticosteroid remediable hyperaldosteronism is autosomal dominant disease characterized by chimeric gene between 11-beta hydroxylase and aldosterone synthase with varying degrees of hyperaldosteronism which responds to exogenous glucocorticosteroids. And family hyperaldosteronism type 2 is an autosomal dominant disorder of both the aldosterone-producing adenoma and idiopathic hyperaldosteronism. Clinical presentation of hyperaldosteronism. The picture varies from asymptomatic to symptoms related to hypertension, hypokalemia, or both of them. Patients may have headaches, polyuria, nocturia, polydipsia, paresthesias, weakness, and muscle cramps. There are no specific physical findings. The degree of hypertension is usually moderate to severe and may be refractory to conventional antihypertensive agents. Malignant hypertension and leg edema are rare. The left ventricular hypertrophy is disproportionate of the blood pressure and improves after treatment of primary hyperaldosteronism, even if hypertension persists. Next one, here we see scheme with signs and symptoms of primary hyperaldosteronism. As you can see, they can be pulmonary, like increased prevalence of obstructive sleep apnea. Bone system, it is increased rates of osteoporosis, increased urinary calcium excretion, and increased risk of vertebral fractures. Renal signs, it is higher beta-2 microglobulin excretion, it is increased prevalence of chronic renal failure, increased cyst formation, higher serum creatinine, inflammations, podocytes injury, fibrosis. Oxidative stress and endothelium dysfunction, increased collagen deposition in small arteries, increased intima to media thickness in muscle and smooth muscle. Metabolic disorders, it is increased prevalence of metabolic syndrome, it is increased body mass index, it is increased prevalence of diabetes mellitus. Cardiovascular manifestations, left ventricular hypertrophy, we understand that mostly due to hypertension. It is inappropriate left ventricle mass regardless of presence of left ventricle hypertrophy. It is increased risk of cerebrovascular accident. increased risk of cardiac ischemia and increased risk of atrial fibrillation and other tachyarrhythmias. And it can be neuropsychiatric disorders like increased prevalence of anxiety and depression, particularly in women. In laboratory tests, primary hyperaldosteronism can be seen like slightly high serum sodium levels, nearly at rate 143 to 147, in hyperglycemia, hypokalemia, metabolic alkalosis, and hypomagnesemia. Although most patients with hyperaldosteronism are not hypokalemic, and low serum potassium level may be noted either spontaneously or after thiazide or loop diuretic use. Hypokalemia may be severe and difficult to correct. Hypokalemia presence reduces the secretion of aldosterone, should be corrected before the laboratory evaluation of hyperaldosteronism. Okay, in diagnosis, the workup of patients with primary aldosteronism involves the following steps. It is screening test for primary hyperaldosteronism, establishing the autonomy of aldosterone secretion and determination of the source of hyperaldosteronism. The categories of patients, it is hypertensive with spontaneous or thiazide-induced hypokalemia, it is hypertensive resistance and hypertensive with adrenal Incidentalomas. Here you see algorithm of diagnosing of primary hyperaldosteronism. Like an example, here I want to show you a CT scan of adrenal glands, and by the blue arrow you see the tumor that we usually name like adrenal adenoma. For screening test, although hypokalemia in hypertensive patient is suggestive of hyperaldosteronism, normokalemia does not exclude this diagnosis. Measurement of 24-hour urinary potassium level can be useful to assessing the cause of a low potassium level. Urinary potassium excretion more than 30 per 24 hours in patients with hypokalemia suggests primary hyperaldosteronism if plasma renin activity is low. The ratio of a plasma aldosterone concentration to their relation PAS to PRA is best screening test for primary hyperaldosteronism. Spironolactone and eplerenone should be discontinued for 6 weeks before testing. Low or suppressed PRA during therapy with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers suggest hyperaldosteronism. Okay, and scheme for differentiating aldosterone-producing adenoma from idiopathic hyperaldosteronism. Yes, for potassium and HTN concentrations, for APA anti-HTN more severe, higher likelihood of hypokalemia, and for idiopathic form, HTN less severe, less likelihood for hypokalemia. Upright posture test. For adenoma, it is decrease less than 30% increase of serum aldosterone level, and for idiopathic, increase more than 30% of serum aldosterone level. For 18-hydroxycorticosterone, it more than 100 nanograms per milliliter in adenoma and usually less than 100 nanograms in idiopathic form. For CT scan, Adenoma we usually can find, and we don't find any tumors in idiopathic forms. And in bilateral adrenal venous sampling, we see lateralization for adenoma and no lateralization for idiopathic form. Next test for you. A 47-year-old male presents with a primary complaint of generalized muscle weakness. Serum chemistry analysis reveals a pH of 7.6 and potassium level of 3.2. Abdominal CT imaging is positive for a 1.5 centimeters nodule noted in the cortical region of right adrenal gland. Which of the following findings are most likely to be seen in these patients? First option, increased secretion of renin by renal juxtaglomerular cells. Second, increased serum level of 17-hydroxyprogesterone and deficiency of 21-hydroxylase. Third one, hypotension secondary to decreased plasma aldosterone. Fourth, hypertension with low plasma renin activity. And last one, increased fractional excretion of sodium and associated hyponatremia. As usually, I'm waiting for your answers in comments. Okay, medical history, clinical findings, and screening workup for primary hyperaldosteronism. Patients with suspected hyperaldosteronism. PRA, plasma renin activity. PAC, plasma aldosterone concentration. We can check aldosterone renin ratio 24 hours ABPM. Ambulatory blood pressure monitoring. We should check left ventricle. We usually check levels of electrolytes like potassium, sodium, magnesium, and aldosterone adenoma, and other visualization findings. In medical history, we usually can find fatigue, muscle weakness, polyuria, polydipsia, constipations. Clinically and laboratory findings due to 24-hour ambulatory blood pressure monitoring, we find severe hypertension and decreased nocturnal dipping. During echocardiography, it is left ventricle hypertrophy. In lab test, increased aldosterone, decreased renin, sodium, magnesium, decreased potassium, magnesium, increased sodium, and metabolic acidosis in plasma tests. In urine test, increased aldosterone and potassium, decreased sodium and pH. Treatment of primary hyperaldosteronism. The treatment goals are reduce the morbidity and mortality. Unilateral adrenalectomy results in normalization of hypokalemia and improvement in hypertension in all patients. Medical treatment is reserved for patients with idiopathic forms or those with adenoma forms who are pure surgical candidates. Spironolactone and eplerenone is a treatment of choice from pharmacological medicines. Side effects include painful gynecomastia, nausea, headaches, impotence, and irregular menstruation. Eplerenone that block the aldosterone receptors selectively has the better side effect. In the use of mineralocorticoid is usually not necessary. Treatment and diagnosing algorithm for primary hyperaldosteronism. Yes, in positive screening test, when aldosterone renin more than 20 and aldosterone more than 15, it is positive confirmatory test like aldosterone suppression testing. After it, we do adrenal CT scan in unilateral nodule. If we find it, we should provide surgery. After confirming adenoma with lateralization. If we find normal on multiple nodules or uni or bilateral enlargement, we do testing with lateralization too and provide a medical management. Okay, a little bit another form of primary hyperaldosteronism. It is glucocorticosteroid remediable hyperaldosteronism. The familial hyperaldosteronism type 1 or glucocorticosteroid remediable hyperaldosteronism individuals are younger than 40 years, exhibit hypertension resistant to standard therapy, and have a familiar history of primary hyperaldosteronism or cerebrovascular accident at young age. Most have a normal serum potassium level, a very high urinary AT-hydrocortisol level, or genetic testing to detect a chemical gene establish the diagnosis. Affected individuals should have neurovascular screening for aneurysms. Treatment with glucocorticosteroids, eplerenone, spironolactone, and amiloride and triamterene is effective. One more test. A 33-year-old male presents to his primary care physician with complaints of headaches, muscle weakness. His physical exam is entirely within normal limits except for blood pressure that is 150 by 95 mm hydrarchium. Subsequent routine blood lab work showed a sodium level of 146 and potassium level of 3.0. What is the best pharmacological therapy for these patients? Options for you. It is hydrochlorothiazide, spironolactone, propranolol, lisinopril, or fludrocortisone. And next disorder for today, it is pheochromocytoma. Pheochromocytomas are rare chromaffin cell tumors that may occur in any age. Although their true prevalence is unknown, they occur about 0.3% of hypertensive patients. If untreated, pheochromocytoma can have severe consequences such as myocardial infarction, heart failure, cerebrovascular accident, and death. Anatomical consideration and etiology of pheochromocytoma. Most of these tumors are benign, sporadic, unilateral, and located within the adrenal gland. Extraadrenal pheochromocytomas or paragangliomas occur about 15% of cases in the superior and inferior para-aortic areas, including the Zuckerkandl organ, bladder, thorax, head, neck, and pelvis. Paragangliomas tend to occur in younger patients, less than 20. They are multifocal and in about 15 to 30% of all cases in young patients. Bilateral pheochromocytoma are usually seen as a part of familiar syndromes. Malignant pheochromocytomas have a higher prevalence in ectopic pheochromocytoma, lower prevalence in familiar pheochromocytomas. About 10 to 15% of all pheochromocytomas are hereditary in nature. In clinical manifestation, patients with pheochromocytoma may have paroxysmal hypertension, it's nearly half of all patients, or persistent hypertension, like nearly 30% of cases, or much more rare, in 13% of cases, they can be normotensive. Wide fluctuations in blood pressure and resistance to antihypertensive medications are typical of those with pheochromocytomas. The triad of headache, palpitations, and diaphoresis suggests the diagnosis of pheochromocytoma, but absence of these symptoms does not exclude the disease. Attacks are usually precipitated by emotional stress, exercise, anesthesia, abdominal pressure, or ingestion of tyramine-containing foods. Symptoms include pallor, flushing, orthostatic hypotension, weight loss, dyspnea, polyuria, polydipsia, visual blurring, focal neck syndrome, and change in menstrual status. The diagnosis of pheochromocytoma can be established by blood measurement catecholamines. It is epinephrine and norepinephrine, and metanephrines in plasma blood or through the 24-hour urine collection. Care should be taken to rule out other causes of adrenergic adrenaline-like excess like hypoglycemia, stress, exercise, and drugs affecting the catecholamines like stimulants, methyl-dopa, dopamine agonists, or ganglion-blocking antihypertensives. Various foodstuffs like coffee, tea, bananas, chocolate, cocoa, citrus fruits, and vanilla. They can also affect the effects of urinary metanephrine or vanillin mandelic acid. Imaging studies of head, neck, chest, and abdomen localize the tumor. And one more test for today for you. It is a 49-year-old male patient presents with a primary complaint of several recent episodes of severe headache, sudden anxiety, and racing heart. The patient originally attributed these symptoms to stress at work. However, the episodes are becoming more frequent and severe. Laboratory evaluation during such an episode reveals elevated plasma-free metanephrines, which of the following additional findings in patient is most likely? First one, it is decreased 24-hour urine vanillin mandelic acids levels. Second option, episodic hypertension. Third one, anhidrosis. Fourth, diarrhea. And last one, hypoglycemia. I'm waiting for the answers. Here we see examples of CT scans. In first picture, you see a 2 centimeters left adrenal mass. It is a tumor. Second picture, it is MRI imaging that shows you a very large adrenal mass with a large tumor. And last one, it is MRI revealed a quite big tumor in right adrenal gland too. You see it by black arrows. Treatment of pheochromocytoma. It is surgical resection of tumor in the treatment of first choice. Other surgical options require prior treatment with the non-specific and irreversible alpha adrenoreceptor blocker phenoxybenzamine or short-acting alpha antagonists like prazosin, terazosin, and doxazine. Once the pheochromocytoma has been resected, thereby removing the major source of circulating catecholamines, and situation arises where there is both very low sympathetic activity and volume depletion. This can result in profound hypotension. Therefore, it is usually advised to load pheochromocytomas patients before their surgery. And last test for you for today. A 34-year-old female patient to emergency room with headache and palpitations. She is sweating profusely and appears tremulous on exam. Vital signs are as follows: heart rate 120, blood pressure 190 by 110, respiratory rate 18, saturation is 99 in room air, and body temperature 37. Urinary metanephrines and catecholamines are positive. Which of the following medical regimens is contraindicated as a first-line therapy of these patients? First option, phenoxybenzamine, nitroprusside, propranolol, labetalol, or lisinopril. Okay, adrenal hyperandrogenism, the last syndrome for today. Let's discuss. The adrenal glands are an important source of androgens. You remember that they not produce just in other organs, especially in children and women. The primary adrenal androgens, like dihydrochloroepiandrosterone and dihydroepiandrosterone sulfate, are under ACTH control and have little intrinsimic androgenic activity. However, they are converted to androstenedione and then to testosterone and estrogen in both the adrenal gland and peripheral tissues. Dihydroepiandrosterone and dihydroepiandrosterone sulfate are responsible for adrenarche. Peak levels occurs in third decade of life and decline to 25% of peak levels around the age of 80 years. In hyperandrogenism, clinical manifestations, here we discuss mostly in childhood because the most cases we see in children. In female neonates, androgen excess causes female pseudo-hermaphroditism, like ambiguous genitalia. Male infants exhibit penile enlargement. At puberty, androgen excess manifests as increased rate of growth in head and skeletal maturation with premature epiphyseal fusion and short adult height. Boys exhibit penile enlargement here, growth in androgen-dependent areas, deepening of the voice and other secondary sexual characteristics. Girls have hirsutism, acne, and clitoromegaly. At puberty, androgen excess causes premature skeletal maturity and short adult height in boys, amenorrhea, different signs of virilization, and increased skeletal maturation, resulting in high height in girls. In adults, in men, a decrease in size of the testicles, testosterone secretion, and spermatogenesis caused by inhibition of gonadotropin secretion may occur. In women, hirsutism, acne, menstrual irregularities, male pattern baldness, infertility, decreased breast tissue, increased muscle mass, android body habitus, and clitoromegaly may occur. Management of adrenal hyperandrogenism. Management of different hyperandrogeneous symptoms or symptomatic therapy, the use of anti-androgens such as cyproterone, acetate, spironolactone, or flutamide. Sapropteron acetate, it is a synthetic steroidal anti-androgen, progestin, and anti-gonadotropin. Spironolactone is aldosterone agonist, we discussed in a previous disease, and flutamide, it is a synthetic non-steroidal anti-androgen. Okay, and one other form like non-classic congenital adrenal hyperplasia. Non-classic congenital adrenal hyperplasia is characterized by milder enzyme dysfunction and manifests commonly in adolescence or adulthood. Although some patients with a non-classic congenital adrenal hyperplasia may be asymptomatic, hirsutism is the most common symptom. The ACTH stimulation test is the best screening test for evaluated adrenal gland functions. Asymptomatic patients with non-classic congenital adrenal hyperplasia do not need glucocorticosteroid treatment. If the main concern the patient is infertility, ovulation, ovulation in female, the treatment of choice. The patient seeks medical advice because of hirsutism. In this case, androgens may be used. Androgen-secreting adrenal tumors. Primary adrenocortical carcinoma. It is a very dangerous disorder that may be associated with excess androgen secretion, and sometimes cortisol may also occur. Primary adrenocortical carcinoma is a rare disease with an incidence of 1 per 600,000 to 1.5 million of people, a prevalence 4 to 12 per 1 million people. Female patients may exhibit virilization with very high levels of dehydroepiandrosterone sulfate, testosterone, and urinary 7T ketosteroids. Primary adrenocortical carcinomas are highly malignant with a poor prognosis. Tumors are usually larger than 6 centimeters, invade the capsule with early manifestation, and typically they recur after surgery. And one more name for today, it is adrenal incidentaloma. Adrenal masses are often discovered incidentally and they are then termed adrenal incidentalomas. The differential diagnosis of adrenal incidentaloma includes many primary, metastatic, benign, and malignant entities. The treatment for hormonally active functional adrenal incidentaloma is surgery. The treatment for malignancy depends on the cell type, spread, and location of primary tumor. Non-functional adrenal incidentaloma is non-premalignant, and surgical exertion in this case is not indicated. Consideration in pharmacologic use of glucocorticosteroids. Pharmacologic doses of synthetic glucocorticosteroids are used in a wide variety of diseases for their anti-inflammatory and immunosuppressive effects. Two main clinical problems arise with chronic use of pharmacological doses of glucocorticosteroids: iatrogenically induced Cushing syndrome and adrenal insufficiency on abrupt cessation of therapy. Alternate day therapy, the avoidance of nighttime doses, are associated with less suppression of hypothalamic pituitary adrenal axis after discontinuation of glucocorticosteroid therapy. Prognosis and prophylaxis of adrenal disorders. Prognosis depends strictly from the disease nature, their clinical manifestations, quality of treatment, and complaints of all its prescriptions. There are no known lifestyle changes to lower risk of developing essential adrenal gland disorders. The following dietary and lifestyle considerations may support healthy adrenal functions: avoiding simple carbohydrates, calorie restriction, limiting stimulants, exercising, maintaining a positive outlook and good self-esteem, adequate sleep, and regular meals, etc. For these very good recommendations, I want to finish our today's lecture. I hope was very usable and interesting for you. One more time, I want to say that I'm waiting for your names, groups, and answer on my test in comments under this video. Sorry in some not correct moments. Yes, I'm not a blogger, but I hope in future this kind of work will be interesting for you, and I will give you more very usable and very interesting information.